Bismillah ar-Rahman ar-Rahim. Assalamu alaikum. Today we are going to discuss inflammatory bowel disease. We shall have an overview. What's inflammatory bowel disease? What are its types? What are the main etiological factors? And few words about the pathogenesis. And then we shall discuss how to diagnose inflammatory bowel disease and how to treat inflammatory bowel disease. Remember, this is an overview. We are not going into the details of any segment. The aim is to make an outline for the subsequent discussions on the inflammatory bowel disease. Bismillah ar-Rahman ar-Rahim. As said in the intro, the topic for today's lecture is Overview of Inflammatory Bowel Disease. The learning objectives. By the end of this lecture, you will be able to understand the basic pathophysiology and classification of inflammatory bowel disease, to differentiate between ulcerative colitis and Crohn's disease, to diagnose inflammatory bowel disease using clinical, endoscopic, radiological, and histological criteria, to understand the pharmacologic and non-pharmacologic management strategies, to recognize complications and know when to refer to the specialist, and to appreciate the role of nutrition, psychological care, and patient education. So we start from a simple question: what is inflammatory bowel disease? It's a chronic, relapsing inflammation of the GI tract. So in simple words, the medical student's definition of inflammatory bowel disease is that it's a chronic, rather lifelong, relapsing inflammation. Inflammation comes and goes of the GI tract. There are two main types of inflammatory bowel disease, and these are ulcerative colitis and Crohn's disease. Inflammatory bowel disease affects young adults, often with lifelong implications. So, this is not just a GI issue, it's a systemic, immune-mediated disease with multi-system involvement. So, I repeat, inflammatory bowel disease is not just a GI issue, it's a systemic, immune-mediated disease with multi-system involvement. So what is the global and local burden of inflammatory bowel disease? The global incidence of inflammatory bowel disease is rising. Studies show that what the incidence was 3-4 decades earlier, now it's increased. In Pakistan also, there's increasing diagnosis rates due to better awareness in diagnostics. And this is across the world. Now, the threshold for diagnosis is lower down, there's better awareness, and better diagnostics facilities are available. So we are diagnosing more cases now, even in smaller cities. Often misdiagnosed as IBS or infections in the start. So people was having inflammatory bowel disease, but their doctors, their healthcare workers thought it's just an IBS or GI infections. But with the better diagnostics facilities, the diagnosis of inflammatory bowel disease is made more frequently. What's the pathophysiology? There's genetic predisposition and environmental triggers. So these two, genetic predisposition, someone is genetically predisposed to develop inflammatory bowel disease, and then there are environmental triggers, and this leads to a dysregulated immune response. And that's the reason immune modulating drugs or immunotherapy has the main role in control and giving remission of inflammatory bowel disease. There's loss of intestinal barrier function, and this leads to chronic inflammation. The key cytokines in the pathophysiology or the pathogenesis of inflammatory bowel disease are TNF alpha, interleukin 12, and interleukin 23. So these are the three main cytokines which mediate the chronic inflammatory process and leads to the damage caused in inflammatory bowel disease. So this picture is telling us the involvement of the colon in ulcerative colitis and in Crohn's disease. In Crohn's disease, when it involves the colon, it's patchy. You see here in this patient, in the start of the ascending colon, the cecal area, it's involved, then the hepatic flexure, then the transverse colon, and then the part of the descending colon. So it's a patchy involvement in multiple involvements. But when you come to the ulcerative colitis, the disease starts from the rectum and extends proximally. So the rectum is always involved. Very rarely we may see cases where rectum is spared. Otherwise, this is involved, and the inflammation extends proximally to the different extents of the colon. So this is the difference between these two. In the ulcerative colitis and in the Crohn's disease, when the ulcerative colitis is a disease of colon, while the Crohn's disease can affect GIT from the lips to the anal areas. So when it is involving the colon, the pattern of involvement of the colon is patchy at multiple sites. This is a diagram showing the changes in the ulcerative colitis. As I said before, there's continuous inflammation to a different extent, and in the colon wall there are ulcers. It's an ulcerative surface, and that's the reason it is called ulcerative colitis. Colitis means inflammation of the colon, and ulcerative, the mucosa is ulcerated. It is characterized by the ulceration. While on the Crohn's disease, as I said, there is a patchy inflammation in the colon, in the small intestine, and there's cobblestone appearance of the surface. Here, these are ulcerative surface. Here is the cobblestone appearance of the surface. Fistula may form, and the walls get thickened. So thickening of the colon wall, fistulae, in cobblestone appearance of the surface. Let's proceed further. This is a healthy colon. A normal mucosa with normal vascular pattern. This is ulcerative colitis. Inflammation is started in the rectum, proceeding till the splenic flexure. And what we see here, there are changes in the mucosa as compared to the Crohn's colitis. And in Crohn's, this is the patchy appearance. So, if we enumerate the difference between ulcerative colitis and Crohn's disease. The ulcerative colitis affects colon only. The inflammation is superficial. It is confined to the mucosa. There is almost always rectal involvement. And fistula and strictures are rare. And granulomas are absent. These are the 5 main features of ulcerative colitis. It affects colon only. It is characterized by superficial or mucosal inflammation. Rectal involvement is almost always there. Fistula strictures are rare and granulomas are absent. But when we see the Crohn's disease, it can affect any GI segment, as said before. The inflammation is transmural. Here, the inflammation is confined to the mucosa, while in Crohn's, it is transmural. And rectal involvement is often spared. Rectum is often spared, while in the ulcerative colitis, it is almost always involved. The fistula strictures are common in Crohn's disease, and they are very rare in the ulcerative colitis. And granulomas are often present in the Crohn's disease, while they are absent in the ulcerative colitis. This is the classification of the extent of the Crohn's disease. You see the ulcerative colitis, proctitis when it involves only the rectum, then distal colitis, rectum and the descending colon, then pancolitis, the whole colon, and even the backwash ileitis. While the Crohn's disease, it may involve the colon, it may be just colonic disease, it may be ileocolonic when the colon and ileum both are involved, or it may be having the terminal ileum involvement. So the different classification, it's not only this classification, there are so many other classifications for the severity and for the extent of the ulcerative colitis and the Crohn's disease. We will discuss those when we discuss these in detail. As I said before, today is discussing or having an overview of the inflammatory bowel disease. So what are the clinical presentation? The patient presents with abdominal pain and diarrhea, which is bloody in ulcerative colitis. Patient also has symptoms of weight loss, fatigue, and the most important point is extraintestinal manifestations. These are very common, and remember, the extraintestinal manifestation may appear before the main disease of inflammatory bowel disease, and they may happen when you have controlled the inflammatory bowel disease, it has gone into remission. Even then, the extraintestinal manifestations may appear. And what are these? It's the musculoskeletal, skin, hepatobiliary, and eyes. In the musculoskeletal, arthritis and enthesitis. Then in the skin, pyoderma gangrenosum, erythema nodosum, Sweet syndrome, aphthous stomatitis. In the hepatobiliary, manifestations are primary sclerosing cholangitis. And in the eyes, episcleritis, uveitis, and iritis. So all these are the extraintestinal manifestations of inflammatory bowel disease. Like here, the aphthous ulcers. This is the Sweet syndrome. This is the erythema nodosum, pyoderma gangrenosum, periosteal pyoderma gangrenosum. Then this is the episcleritis, uveitis with hypophene and dilated iris vessels. This is the conventional X-ray of the lateral spine demonstrating syndesmophytes, that is the bamboo spine. This is the plain radiograph of the iliocecal joints with bilateral sacroiliitis. The distinction is almost gone. This is the plain radiography of the sacrum with bilateral ankylosis. And this is the coronal magnetic resonance imaging MRI of the sacroiliac joints with active inflammation, mainly on the left side, and chronic inflammatory changes on both sides. So what about the diagnostic workup? We do the lab tests. Of course, after listening to the patient and doing examination, we do the lab tests, which involves complete blood count, ESR, CRP, and fecal calprotectin. Then the stool studies to rule out infections. Of course, endoscopy is the cornerstone diagnostic tool, colonoscopy with biopsy, imaging, CT, MR, enterography for Crohn's disease. So these are the different diagnostic tools or workup, how we proceed to make the diagnosis. What's the diagnostic criteria? It's based on, the diagnosis is based on combination of clinical history, endoscopic appearance, the colonoscopic appearance, histological confirmation, and of course, radiological features at times. What are the common mistakes and which should be avoided while dealing with inflammatory bowel disease? One is that most of the times inflammatory bowel disease is confused with IBS. But remember, in IBS, there is no weight loss, there are no constitutional symptoms, there is no bloody diarrhea, and of course, when we listen to the history, it is suggestive that whether this is IBS or inflammatory bowel disease. But to start with, the patients with inflammatory bowel disease are often misdiagnosed as IBS. Then overuse of steroids. Steroid is the mainstay of treatment of the inflammatory bowel disease, and at times it is used for longer time, for more than required time. Then delayed referral to specialist. And we will be discussing in the next lecture the delay in diagnosis. So the delayed referral to specialist results in advanced stages or the complications to happen. Then ignoring mental health. This is again a very common mistake. We treat the patient is treated, tests are treated, and the mental health is not given the due attention which that patient deserves. So coming to the treatment, what are the treatment goals? Treatment goals are, of course, number one, to induce remission, control the inflammation, control the disease. Second is maintain remission. So first of all, induce remission and then keep it in remission, or you control the disease, you control the inflammatory activity, and then you keep it controlled. Of course, improve quality of life is the third main treatment goal, and to prevent complications and surgery. Because if you don't diagnose in time, if you don't well control the inflammatory bowel disease patient, then complications are unavoidable. So role of biologics, and we'll be discussing this in detail in the coming lecture. So these are indicated in steroid refractory or fistulizing disease. And what are these? Anti-TNF, infliximab, adalimumab, then anti-integrin, vedolizumab, IL-12 and 23 inhibitors, that is the ustekinumab. So one is their stepwise treatment in ulcerative colitis. What is that? In mild, 5-aminosalicylic acids or mesalamine is given. In the moderate, corticosteroids are added. And in the severe, biologics are added, including anti-TNF and vedolizumab. Then in the fulminant case, surgery is considered. Same is the stepwise treatment in Crohn's disease. And what is this? In mild to moderate, budesonide and azathioprine is given. and in moderate to severe, biologics are given. And in complicated Crohn's disease, surgery and immunosuppressants are given. Remember, in the next lecture, we will be seeing whether the stepwise treatment approach is the right one or should we do something else. Monitoring therapy, this is again very important. To control the symptoms, clinical symptoms, you monitor the patient by keeping the record of the clinical symptoms, fecal calprotectin, and colonoscopy for mucosal healing. And of course, drug levels and antibody testing if the patient has been started on biologics. Nutritional support is very important. Malnutrition is common in inflammatory bowel disease, so enteral nutrition is preferred. Vitamin D, B12, iron supplementation is very, very important. What about surgery? In ulcerative colitis, it's a curative surgery, means total colectomy. In Crohn's disease, surgery is not curative, it is used for strictures, fistulas, and abscesses. And of course, the pre and post-op biologic therapy considerations are very, very important. Psychological aspects. These patients, they are anxious, they are in depression, and that needs to be addressed. The young patients struggle with chronic illness, and again, they need psychological support. And the role of support groups and counseling is very, very important. So, subscribe to my channel, The Medicine Made Easy, by the name of Professor Dr. Javed Iqbal FAROOQI, The Medicine Made Easy, to see the other lectures on this topic and on the other topics of the medicine. Inshallah, I see you in the next episode of our discussion on inflammatory bowel disease, that what should be the comprehensive management plan for inflammatory bowel disease. Till then, take care. Khuda Hafiz.